A bit different today. We've got slightly longer lectures, most of which will have two speakers buddying up, and they'll be talking about all the different things related to chronic pain, osteoarthritis, medicine, surgery, and so on and so forth. A little bit of housekeeping for you then. I can see a lot of you are joining the webinar. Now you have two options if you wish to view. You can just view from the lobby live stream. If you wish to have translated subtitles, if English isn't your first language, then the lobby live stream is the place to do that. Click on the little CC button and you can choose your language. If you'd like to interact with questions and chat, then come into the webinar itself. You click the pink join button and you should be coming through to us. Please do feel free to send through your questions. We've allocated some time at the end of each talk to a Q&A session, so our host will be reading through them as the webinar goes on, putting them in some semblance of order, and then we'll have a facilitated discussion towards the end. If you have any technical problems, the chat in the webinar is open. I'll also be in the lobby. We have a team working, so do let us know wherever you are and whatever's happening. We'll try to get you back up and running as quickly as possible. Massive thank you to the sponsors of this event. Without them, it simply wouldn't be possible, as I'm sure many of you know, especially not to bring the whole event to you free of charge this weekend. So for this first talk, a massive thank you to Animal Care for their involvement. I'm going to bring my colleague Hannah into the fold now, who's going to do some introductions, and I'll disappear into the background.
Thank you, Paul. Thank you, everybody, for joining us early on this Saturday morning here in the UK, EU, wherever you are. This is an incredible event because we've got amazing speakers like the two that are just about to start speaking to you now. This is Dr. Matt Gurney and Dr. Carl Bradbrook. They are the founders of Zero Pain Philosophy. They both work in referral practice, and they are going to be talking to you about a very, very topical area. Gold standard is dead. I'm going to step out and leave you in their capable hands.
Hi everyone, welcome. So we're going to cover Gold Standard is Dead, Embracing Evidence-Informed Contextualized Care. We don't have any conflicts of interest to declare, and our clinical decisions for animal welfare. So what have we thought about? What do we encourage everyone to think about? Engage with a pet owner as early as possible. Be clear and use appropriate terminology. Identify pets with signs of pain using validated assessment tools, and we're going to touch on some of those tools today. And you're going to hear us talk about a pet-centered approach to pain treatment and pain management. So let's get started. Carl.
Thank you. I think this is a really, really important topic, and something that I am quite passionate about as we adapt and we modify the way that we approach pain management, as well as other aspects of veterinary medicine. I thought it'd just be interesting just to touch here on this term gold standard. It's thrown around a lot, and where did it come from? Originally, I understand, from the financial industry, and then this became a concept that was adopted by human medicine. From there, then vet medicine adopted as well this term, and I think we see it as that to provide gold standard care, we need to do what we feel is the most advanced, the most technically skilled of either treatments or procedures or patient care, and that's really where the focus has come from as we've utilised this term. You may have come across just this first reference that I picked out here, which was from the Vet Record. This was a debate or an opinion piece in 2021, and I think this really started that change as people have thought more about whether this is something that always fits in with the care that we are providing. Something else just to touch on here is the difference really that was focused, and this is a really great piece to look at, was the differences between what treatment is. So a very specific option where we're treating something that we can see, that we can diagnose, for example, versus patient care or pet care, which is really that holistic approach to the whole animal. I think that really fits in really nicely with chronic pain. Just coming back to this first point then, in terms of why do we think this is gold standard is dead, and we are focusing here on what are the concerns with using that? Why are we worried about this? And that comes down to the pet owner, but also to the professional, so to ourselves that are involved in that animal's care. And they can be both moral in terms of the care that we can or can't provide, as well as those financial aspects as well. So can the owner afford what we feel might be gold standard and therefore what they expect? Certainly, as vet medicine has developed, there's some great treatments. We've got great options now as to how we can manage some of the presentations that we see. And therefore, there's an expectation that perhaps the owner expects that they can access that care, as well as the fact that they think that their own pet should receive that care. The downside to that is that those owners that feel like either they can't afford or they wouldn't choose that may not even go to seek any opinion from a vet, and therefore there's a potential for impact on animal welfare, and that could be obviously a negative impact. The final thing really I just wanted to touch on as we kind of start this is then what has developed out of this is a practice of defensive medicine. So we're perhaps choosing to perform tests, diagnostics, and even potentially treatments that we're doing because we feel like we should do, because if we don't, and we may open ourselves up perhaps to litigation. And that with it perhaps comes a lack of flexibility on the part of the vet or the professional. So really, just to kind of summarize out of that, where we're kind of starting off, then take home from here is that let's think more globally, more holistically about this triad of care. So we've got the pet, we've got the pet owner, and we've got the professional as well, the veterinary professional. And out of this, we see that there is a validity of treatment pathways with those different contexts that obviously confer some flexibility around what we can offer to that pet owner and therefore to that pet.
So where you say validity of treatment pathways, do we need more guidelines? Do we need a bit more of a NICE approach, the National Institute for Clinical Excellence approach in providing us with those treatment pathways?
I suppose one of the downsides to going down that kind of route is we may not see that flexibility because we're likely then to perhaps enter into one of those algorithms of care, and that may limit what a particular owner, a particular pet could receive, because we can't then maybe see outside of that box. So I think, yes, we need to be better informed, and in certain situations we're well aware of that. But perhaps going down that route is not necessarily the way we want to go.
And I always still think there's a role for balancing the art and the science of what we do, and we're not necessarily robots, and we will have our own experiences. And I guess that is leading us on to contextualized care. And I'm going to say, is or was gold standard always a realistic option?
I think that's a really interesting point. And just coming back to a couple of statements that that this debate opinion piece from the Vet Record picked up is really around this focus that as we come into contextualized care and we think about pet-centered care, that pet and animal welfare is key here, really, and that we are always, or we should always be thinking and focusing on animal welfare. And that, just to pick out these two quotes from this debate piece, is that a belief that animal welfare is better served by active consideration of those most appropriate options for each case, and that is where the context comes in. And rather than this assumption that we always should be providing that top level of most advanced care, that always equates to optimal care. That is something I think that we should be continuously challenging.
So should we dig a little bit more into appropriate veterinary care and what that means?
And this term, this appropriate veterinary care, is I think it kind of encompasses and kind of broadly gives us an overarching kind of feeling as to what we can and can offer to each patient, to each pet that we present to. And that appropriate care will be different. So that's the context there, depending on all of the factors that we just touched on. But by allowing pet owners and pets to have better access to care, then we can always offer something, and that we can pick through. The challenge here, and we'll pick up this in a few slides moving on, around this conflict of expectation of the stakeholders. So by the stakeholders here, if you're looking through the literature in these areas, then you'll pick up the pet owner, pet and professional, kind of this triad of care, which is different to human medicine, and we'll pick up that a little bit later. And just to focus into here, then that challenges us and makes it somewhat more difficult than in human medicine to ensure that we're picking up on welfare, and that this concept of autonomy of care, which we'll also touch on, is something that is completely different in human medicine. So there's not always a comparison.
And I would say it's quite fortuitous for the timing of this talk that this paper that's referenced at the bottom here has just been published, and it helps us explore that question: is advanced veterinary care always appropriate? So let's have a look at this.
A really good question. I picked out just a couple of points here from this paper from Sandra Kaur and her colleagues, looking at this concept of advanced care, and they surveyed pet owners in the UK, Austria and Denmark. And you can see here, just from a statistical perspective, that around 45% of owners were neutral that advanced veterinary care has gone too far, and 40%, just over, agreed that advanced veterinary care is unnecessary.
But that means that 55% of owners do want advanced veterinary care.
Yeah, absolutely. And one of the things that came out of it from a clinical significance perspective, they looked at emotional attachment scoring, and those owners that had that high level of emotional attachment to their pet are more likely to believe they should have the same treatment options as those that are accessible to ourselves, to human patients. And I think we see that clinically, don't we? We know, certainly in our practice, that by the time the pet and the pet owner come through to a referral practice, those owners are likely to have that high emotional attachment associated with the fact that they've gone on to access advanced care.
So if we bring that back to appropriate veterinary care, then where does that leave us?
Well, two things here I think that are really important for us to touch on, and something that I feel we are, we're going down a bit of a rabbit hole in some situations, is that there's a potential for compromised animal welfare. Now, that can be because the owner can't access advanced veterinary care for whatever the reasons might be, but it may also be that by accessing advanced veterinary care, that's not appropriate for that pet, dependent on the situation and that context. So that's one aspect. The second is that by accessing those advanced techniques, again, they may not be appropriate. The pet may not be the most appropriate choice for those. And then we get dissatisfaction associated with having gone down that route, which can obviously also be quite costly in terms of treatment pricing as well.
So I guess the big question: how do we move towards a pet-centered approach to care? I'm kind of doing that with my hands because I'm thinking of a funnel motion to move us towards a pet-centered approach to care.
And I think just here that we've got this nice study from 2020, and looking at this concept of co-produced care, and just a concept I think that's worth introducing here, and that this is something that's well established in human medicine. There's good use of this. This, I suppose, debate and again statement piece really looked at how can we develop this into vet medicine, not well utilised or accepted currently. I picked out these 6 kind of latent components that they talk through in this piece of work. And I think they fit really nicely into this co-produced or this contextualized bespoke care, and something that the qualities of perhaps someone that's able to articulate those well to the pet owner. So empathy, really important, that's bespoke or contextualized component to that animal's care. Professional integrity, can we stand there and be able to deliver that information and communicate that across in a way that the pet owner can engage with? We touched on it on that last slide, of value for money, being able to ensure that we're providing a service that is valued, and that doesn't mean just that it's financially costly. There's a confidence around that relationship. We're well aware that building a great relationship with the pet owner is really important, so that they engage with us, that they listen, and we listen to them as well. And then touching back, perhaps I think it is important for us in small animal medicine, but a concept across the whole of the veterinary field is around accessibility to care, obviously in different climates, but also in different species as well. So we're talking, specifically in some examples here around small animal medicine, but this touches on all aspects of vet care as well.
I think when you say this is well established in human medicine, I think what we mean is the science is well understood, isn't it? Putting it into practice, that's the really hard part. That's us showing up in the consult room every day and actually living this, which is a challenge for everybody, isn't it?
Sure. And the pet in this triad complicates this situation. It isn't as straightforward as it, not saying it's straightforward, but it's not as straightforward in comparison to human medicine, where we've got two parties. We've got the care professional, the care giver, and we've got the care receiver, but we have a complicating factor in the center of all of our relationships.
Maybe this is something that we should be marketing to our pet owners, not, oh, look, come and see me because I'm absolutely brilliant at what I do. Maybe we should be marketing the fact that these are all the really complicated things that go into developing a perfect relationship with our client and offering excellent care for pets. We're complicating things. So where should that autonomy be placed to maintain animal welfare?
And this is a great piece of this critique, which is from Frontiers in 2022, introduced this concept of this autonomy principle. And in human medicine, kind of thinking about that co-produced care, autonomy lies with the patient. Whereas in veterinary medicine, we have, I think, this conflict that we see through there, and that is the vet medicine difference here. We've got this triad of care. So I think just to go through and pick up then on some of the differences and where the challenges might lie in vet medicine, and the consequences of this autonomy principle. Where's it going to lie with? Is it the pet owner? Is it the professional? The pets themselves obviously can't make that autonomous decision, and those challenges are something I think that we face on a daily basis when we're talking to pet owners around what they would like. So this is a really interesting critique to read through, but their kind of take on this is that the triad that's associated with veterinary care corrupts this autonomy principle. But is that I think we could have a great conversation around whether that's the correct interpretation for this. But by sitting that autonomy with the pet owner, there is that potential for impact on animal welfare if the pet owner chooses a treatment that they think the pet should receive, but there's that conflict with the veterinary professional. And that's where that moral and professional stress comes in. And I think that's something that we've all experienced when we don't necessarily think that is the best choice in that situation.
I think we live that every day, don't we?
Absolutely. And just that recognition that we are making a decision by proxy, whether that's us as the professional or whether that's the pet owner, making that decision, we are doing that by proxy for the pet, for the animal that is involved in, in that situation. So really important to, I think, just to think about these things, have great discussions within the clinical teams around what that means.
And I think everything that we've talked about so far is leading us to that need for a redefinition. So what is contextualized care?
Absolutely. And I think this is a great definition. Again, it came out of the statement piece that kind of first started, or first kind of put this in the spotlight. And contextualized care then acknowledges that there are different treatment pathways are able to offer equally acceptable patient journeys in different contexts, and they're all with the aim of this kind of concept of a good outcome. Now, the good outcome will be different depending on the presentation, but that is the absolute aim here, and I think that's a great focus for moving on to.
Yeah, and I've got some examples around pain management. I'm sure we've heard a lot about how to manage certain types of pain. I guess let's think about where we're suspicious of OA pain. How do we think about that in the concept of contextualized care? I think what is helpful, we talked about the need for guidelines and maybe giving us a basis on which to practice. I quite like the concept of an analgesic ladder. This is an example of an analgesic ladder for arthritis in dogs, starting at the base with our first option, non-steroidal scrapiprant or bedainvecmab. In a few slides, I'm going to look at the differences or what we know about those. Let's just focus on that second line, because I think that the first line is almost taken for granted in management of osteoarthritis. We need to use the licensed products, and those three are all licensed products. We'll talk about how to choose between them. However, from a contextualized care point of view, what happens when we've done one of those things and the pain is progressing and we need to add in further analgesia? And there will clearly be some clients that absolutely agree that their pet needs further analgesia, and they want that in the form of a medication that they can give every day. Therefore, we need to refer to guidelines. We need an understanding within our practice and for ourselves, what is the next best step? This brings me back to the concept of evidence-based or evidence-informed medicine. Okay, there isn't a huge evidence base to determine what that next step is. There's one study looking at the benefits of amantadine in dogs. Okay, we add to that several years of our experience. So this is where we're merging into evidence-informed. So I'm using the evidence and my experience to inform my decision in the reasons why amantadine is my second line. Okay, amantadine is really expensive. There are some clients that can't afford amantadine. So somebody might say, well, amantadine is your gold standard. And you question, well, actually, is amantadine really gold standard because we have one paper and we have some experience? What about memantine? It is a cheaper option. Experience teaches us, the literature unfortunately can't support us on that. Experience teaches us that memantine is a sensible option. Okay, I'm talking just from a drug perspective here. There are clients that will not want to have a drug approach, and we might be there thinking, well, actually, I know that adding in this drug is going to make a difference to your pet, but the client doesn't want to do that, and we think that's then disappointing for us. We're thinking, well, I can't offer that standard of care that I want to offer, so what do I do? But maybe they're a client that recognizes, and we've got them on board with the fact that everything else matters as far as weight control, diet, exercise, physiotherapy, rehabilitation. And actually, how do we know that going down that route and working really hard on those other options isn't going to give us a similar outcome? Sadly, we don't have that evidence base in order to tell us that absolutely you must adopt this approach. So I think what we're looking at here is that there are several ways that we can move forward with this case to achieve a positive outcome. And the really important thing is looking at our outcome measures and making sure what we're doing is making a difference. So perhaps that's where I would focus in arthritis pain, is looking at the evidence as far as outcome measures go. So.
And I think you refer here then, Matt, to those levels of evidence, those qualities of evidence, and we've termed kind of here we've evidence-based in brackets, evidence-informed vet medicine. So should we have a bit of a look at those levels in an ideal world, and we're looking at, I suppose, collated evidence. So thinking about some trials that have been performed and then collating that through, and just kind of briefly go through how these sit. I mean, just detailed on the slides here. The quality, as the quality increases, or there's a higher evidence level from I suppose the most kind of unstructured of reviews, which is the narrative review, through to a concept that we'll pick up a bit later as well, these critically appraised topics. So more clinically applicable, asking those quite narrow questions, and producing, I suppose, more of a guideline for patient care.
And I think on this topic, I would use the topic of nutraceuticals as a great example. And we're going to hear more later over this weekend from Eric Troncy around nutraceuticals. You can see Eric was one of the authors of this systematic review here. If you open any of our veterinary magazines, if you like, you'll find narrative reviews on nutraceuticals. You'll find reviews on management of arthritis. They will mention nutraceuticals. This is it's really nice to have this systematic review that Eric and colleagues looked very critically at all of the literature associated with nutraceuticals. And I think this can certainly help us focus our practice of managing these pain cases, and answers that question, where is the place for nutraceuticals? Because there absolutely is a place. I don't think this is a throw the baby out with the bathwater. They make some very strong statements here with regards to glucosamine and chondroitin, which I'm sure a number of us will agree with, but they also open the door to the possibilities of other nutraceuticals which may well help our patients. So good, we are seeing systematic reviews, we're seeing this quality of evidence to enable our practice. So I touched on the importance of outcomes, and I think a good example of collated evidence, so where researchers have gone to the lengths of looking at published studies, bringing those studies together, is this piece of work here that looked at owner-reported outcome measures for canine orthopedic care. And what they did is they looked at a consensus-based standards. They looked at 6 owner-reported outcome measures, and there were 3 of them that they deemed to be suitable for the use for osteoarthritis in dogs. Those were the Canine Brief Pain Inventory, the Liverpool Osteoarthritis in Dogs, and the Canine Orthopedic Index. Now, I've got familiarity with the first 2 there. You may well have familiarity with the Canine Orthopedic Index. But this gives us some confidence that we have evidence-informed tools in order to help us measure the impact of the changes that we make, the decisions that we make in ensuring that our treatment pathways are offering a benefit to our patients. So what I would do, I would certainly encourage you to go down the route of using some of these tools in order to guide our decisions. I think it's really clear. I think we can get that really good relationship with an owner if we're really clear with saying, okay, we have these tools, we have these validated tools that can help us work out how painful your dog is, and it can help us guide the impact of any of those treatment options. And even if you've got one of those owners that say, the owner's saying, well, I want to do this, I don't want to take your recommendation. If we can at least get them on board with using a validated tool, then we should be a step closer to working together to document that positive outcome or that negative outcome, and then changing our decision. Okay.
I think just touching on here that these consensus-based options are a great way to focus and to select what we feel is the most appropriate way to perhaps assess or to to measure those
Yeah.
as well.
And I think turning to cats as an example, I feel that this publication is a really good example of what we as practitioners on the front line need in order to guide our clinical practice. And I've just highlighted some of the words in the statement taken from the introduction to this paper, which is the ISFM consensus guidelines on the management of acute pain in cats. I mean, what a beautiful document to have to guide us in managing those cats in acute pain. Created by a panel of experts based on available literature and the author's experience. So to me, this is real evidence-informed veterinary medicine.
Sure, and giving the practitioner, the clinical practitioner, the tools that they really need to be able to practice and to provide that patient care to the best that is available within that context. I think these are great examples of how that consensus-based medicine is informing our clinical practice.
Yeah. So I think now that we've looked, did I just skip a slide there? Yeah, I did. So let's think a little bit about how we can put the pet at the centre of that care provision. How should we use the evidence? We gather our information, and that might be beautifully delivered to us as a team in our practice as a set of consensus guidelines. We've got all the information we need. I would grab hold of those CAT guidelines and say, right, okay, practice discussion, this is how we're going to move forward. That's how I would approach this. And okay, fine, there are guidelines, and I'm sure if I carry those guidelines into any one of your practices, we can have a really good discussion and debate about how that works in the context of our practice. And we can help to define those evidence-informed approaches. So I think as another example that I just want to touch on is, which is the best first-line analgesic for OA in dogs? And you saw me put up the canine arthritis analgesic ladder with our first line options. So we have non-steroidals, Grapiprant and Bed-in-Vetmab. And the reason I say they're our first line is because they're licensed. So let's just have a little look at a recent study for each class of those analgesics. So I've got non-steroidals at the top, Grapiprant in the middle, Bed-in-Vetmab at the bottom. And the reason I've put these all on the same slide is because they use the same outcome measure, which is the Canine Brief Pain Inventory. So taking non-steroidals, using enflicoxib as an example, the findings from this paper were that enflicoxib was efficacious for pain in any stage of osteoarthritis. Looking at the Grapiprant paper here by Rauch-Dera et al., Grapiprant is an effective treatment for the alleviation of pain in dogs with OA. And then at the bottom here, Corral et al. Looked at a multi-site clinical study looking at Bed-in-Vetmab, the canine monoclonal antibody, and their conclusions were that this is an effective product for the alleviation of pain associated with canine osteoarthritis.
And just pick up there that the indications all sound very similar. And coming back to where we've been talking through, how do you go about deciding in that evidence-informed, contextualized care approach? How do we select one of these as our option?
Yeah, I mean, quite right. And what is missing in the literature is we don't have a head-to-head study comparing non-steroidals to Grapiprant or non-steroidals to Bed-in-Vetmab. So we definitely need that information. We need those comparative studies. We need longer-term studies. I think we can always critique any osteoarthritis pain study in the length of comparison. The length of examination of those patients, and then the contextualized bit. So, as far as we're concerned, according to those licensing studies, this seems to be equi-efficacious. Those three classes of drugs for the management of osteoarthritis. How do we tailor that to our individual patient? We've got to think about owner compliance, product tolerability, finance, and like I said before, the owner ability to address everything else, because emphasizing the fact that drugs are just one part of managing arthritis, and actually everything else, diet, weight control, exercise, physiotherapy, pain scoring, pain behaviors, everything else is equally as important, and we're not going to achieve success unless we can address everything else. Those are some of the things that I think about. And I think what this this really brings us to is we absolutely need a team approach. So if we wanted to talk about first line management of osteoarthritis, great option for a practice discussion. What do we think together? We know one of the critiques that we get from pet owners is, oh, I often don't see the same vet twice. So I see that as a reason to get everyone in the practice even more on the same page. And by everyone in the practice, I mean all of the professionals there, so the vets, the nurses, the receptionists, absolutely everyone. So we're standing there in the consulting room with our client, and our rationale for treatment is as robust as it possibly can be, evidence informed. It's something that within the practice we all have consensus on. We can really start to build that bond with the client and get them on board with those treatment options.
Absolutely. I think some really interesting points there just to kind of emphasize is this is a holistic whole team approach, isn't it? And the front of house team are just as important in building that bond and listening to the client and feeding back information as everyone else involved in that patient's care.
Yeah, and I think that is contextualized care. It's care in the context of our practice. Because ultimately, yeah, it's that pet-centered approach. So let's think about filling evidence gaps in a slightly different way. And I'm going to ask the question, what do you think? What's the best local regional technique for stifle surgery? So we're talking about arthritic patients, we're talking about dogs with orthopedic disease. We do nerve blocks every day. We manage these cases every day. What's the best technique?
Good question. I think maybe some of that comes down to what we are comfortable with, what are the techniques that we feel like we can perform and we get the best outcomes. So there's that clinical kind of judgment, isn't there? And a clinical experience as part of that. I imagine you're going to touch a little bit on what we know from a literature perspective as to where we should be going.
Yeah. So before I jump onto that, I think this is a really good study, Pownell et al. They looked at the influence of the choice of preemptive analgesia. And by choice of preemptive analgesia, what they mean is we took 120 dogs. It was a retrospective assessment, and they used the Helsinki Chronic Pain Index to document chronic post-surgical pain in these dogs at the 6-month time point after surgery. They then almost stretched that a little bit to ask the question, if we look at the dogs that got a femoral sciatic nerve block versus the dogs that got an epidural versus the dogs that got a spinal injection of local anesthetic, was the outcome different in one of those groups? So I think let's just jump to what their conclusions were, and then we'll dig in a little bit to that. So what they documented, and you might be surprised about this, you might not, 41% of dogs evaluated exhibited pain scores compatible with chronic post-surgical pain. I'm sure a lot of us are sat here thinking, right, okay, we've got a dog that's having stifle surgery next week, either in my practice or I've referred it or as my own dog. They're going to get better, right? 6 months down the line, that dog's going to be running around absolutely fine. Not according to this piece of work here. Under the clinical significance section, okay, additional studies are required. I never find that very useful in the context of evidence-informed medicine. What I really want to know is, right, tell me exactly what those additional studies that you say are required are. A few things to think about here. So let's just a couple of other clinical significant things there. Weight was negatively correlated with pain, and not all painful dogs received analgesics at the 6-month time point. So let's dig a little bit further into that.
I think something just to mention there is, just question out to the audience, what can we do? What can we do as the practitioner, as the professional, to better capture those pets that are painful post any procedure? How can we pick those up? How can we engage with the client, with the pet owner, get those dogs back to get access to care and to manage their pain? Because I think that's a great point that highlights that we're missing opportunity to improve animal welfare and to engage with those clients.
Yeah, 41% sounds quite a high number. I think when you then start to dig into some of the flaws in that study, you'd maybe recognize certain areas that that could be addressed closer, which is where the additional studies are required. What I would consider really important is the baseline pain state. So I don't think the baseline pain state of 100 dogs undergoing cruciate surgery is exactly the same as another one. If one of those dogs jumps yesterday and ruptured its cruciate catching a frisbee versus that dog that's got chronic arthritis in that stifle or in the other stifle or in other joints indeed, because certainly multi-joint arthritis will contribute to that baseline pain state. We think that Helsinki Chronic Pain Index is a suitable measure. Would a validated quality of life measure be a better option? When we talk about baseline pain state, I'd also talk about stratifying those dogs. So we need to measure their baseline pain state, because I think the dogs with mild pain before the surgery probably have a better outcome than dogs with severe pain. How do we know the nerve block worked? Particularly referencing this study, okay, it was retrospective in nature, and I don't think, certainly all of the nerve blocks didn't work, because the fentanyl consumption during surgery was 33% of dogs received fentanyl. That's pretty high to me. So I would have thrown all of those cases out and said, right, we need to split these into groups where the nerve block worked and where the nerve block didn't work. What's the best post-op analgesic strategy? What's the best pre-op analgesic strategy? Another thing to think about as a practice, how best do we analgese these dogs before stifle surgery? How best do we analgese them post-stifle surgery? We don't have information to tell us how long these dogs need analgesia. But what we do have, we have pain scores, and we should be pain scoring these patients for this study would suggest for quite a long time after stifle surgery. I think if you've got a dog that's had major orthopedic surgery like stifle surgery, that dog probably needs pain scoring for the rest of its life at an appropriate interval. And that's how we're going to ensure these dogs don't get missed.
And I think maybe just to point there that I think Louise Clark's going to speak around this concept of chronic post-surgical pain. And I think that just touches on the fact that we're aware from pieces of work like this one that does exist. So it'd be really interesting to listen to Louise's thoughts around that.
I think that 41% might be a big, whoa, hang on, this is a really big number. Do we believe this? But actually what that is bringing to the floor is chronic post-surgical pain absolutely exists in cases that we think are fairly routine in our day-to-day clinical practice.
So perhaps just a bit of a summary from where we've got to, quite a lot of information and some thoughts around gold standards and around contextualized care, but just, what are our kind of key take home?
Well, I would say, right, let's put ourselves in the position of the audience today, and what are those key take homes? What would be your key?
I think, really, really important for me is just that we should have confidence in providing advanced veterinary care if that is appropriate. But really putting the pet at the centre of that approach, that pet-centric or pet-centred approach, and really just listening to our owners. What does the owner want? Really important to be able to give the time to get them on board with it.
I would say be curious, dig into the literature and ask questions and have that debate. We're here to support. That's why we created Zero Pain Philosophy. We see our role as taking what's out there in the literature, listening to the questions that come our way, and digesting that into something that's useful, something that's bite-sized, something that's understandable, so everybody can provide better pain management to the pets that we look after.
Great.
There we go.
Looking forward to some questions.
Lovely. Can you hear me?
We can hear you.
Yeah.
Amazing. Really amazing opening discussion. And just to remind everybody, the overriding theme of this weekend is how we all work better together. So having been in the chronic pain industry for a while now, there are many amazing people doing amazing things, and we've got to be able to start working together and sharing our knowledge and working in this interdisciplinary approach. So this topic for us was really foundational to start the weekend, because what it does is it brings everybody back into the same room. We all want the same thing and we all have the same challenges. Now, just take the opportunity as some questions come in. I want to know a bit more about the zero pain philosophy. Like, I dig into it all the time. And what I love about it is that you do all the hard work for me. I can just put the podcast on, walk the dog, cook the dinner, and I can have you just harmoniously singing in my ears. But, you know, whilst we wait for a couple of questions, just give us a little bit of a lowdown about ZPP.
We are here to give you the tools that you need to encourage to practice analgesic excellence in your clinic. And we look at that on a global basis. We were co-founded with one of our colleagues, Dr. Brent Higgins in New Zealand. So we love our little global following. We take pieces of information. Originally, we started getting our phones out, filming videos of local anesthetic techniques. That's how we started. So helping people practice on a very practical basis. We've got our pain updates, which are little snippets, topics. When we hear from practitioners, okay, can you tell us more information about this topic? We dig into the literature, we digest it, we present it. We have webinars. We have our Zero Pain Reflect, which is our dissection of the evidence of certain pieces of information. We've got telemedicine. We have our podcasts, like you said, Hannah. We've just recorded a podcast with Professor Paolo Stigal, so that is going to be coming live as soon as,
Wow.
as soon as I edit it. That's supposed to be a weekend job. And we've got our zero pain practice. So our zero pain practice is encouraging practices to work to the very highest standards from an analgesic perspective.
Yeah, I love it. I love it. So we've got a couple of questions coming in. I'm going to dive straight in. Thank you, Mel, for giving your opinions. Thank you all the chat, guys. Really, really lovely messages coming in. If you've got a question, get it into the Q&A box, just because I can't do two things at once. Right, Miriam, great. Yes, WSAVA pain certificate definitely needs mentioning. It is an absolute stupendous feat that Beatrice led with the WSAVA. There is a certificate that anybody of any financial background can access. So it's free of charge to do. It's only going to cost you if you want the certificate to be recognised as your CPD. There is no reason not to dive into improved pain understanding. So thank you, Miriam. Really, really good. Samantha, do you feel those patients that are more painful post-surgery perhaps are already sensitised to their pain prior to surgery, so are more difficult to manage afterwards? Okay, you've got only 2 minutes on this, Matt, because I know that you could do 3 hours on this.
That's really, I'm just going to say yes to that one, Hannah. Listen, I'm going to say yes and listen to what Louise has to say on this topic.
Yeah. So Samantha, you've got to stay with us all weekend, because that topic comes up again and again and again in many different formats, and it's going to stretch our minds. Toby's got a very specific question. I think it's very pertinent. Hi there. Wondered if there are any studies, benefits, pitfalls to using the anti-NGF products prior to a planned orthopedic surgery.
Simple answer, there are no studies at the moment. I'm sure there will be more. These products have just been launched in the States. So once you launch products in the States, people do lots and lots of clinical studies. So I'm sure we'll see that happen.
Yeah, definitely. And I think everybody's got to remember it's fresh, isn't it? It's really fresh. And I was talking to somebody who was around in the 90s and practicing. And when some of the non-steroidals came out, they were like, oh my God, everybody's got this polar opinion about these products. And there were sites that was Metacam kills and Remedil's death, and all of these things were coming out. And look at them, they're established parts of our protocol now. We know how to use them better, they fit in, we've got confidence. These field trials have led to a greater understanding of their capabilities. And I think people have got to give Bedinvetmab a little bit of time. It's pretty new on our... How do you feel about that?
With everything, you look at you have to get a certain amount of literature to get a marketing authorization, get your product on the market. That's what you need. We don't stop looking at these. Okay, whilst the drug company might not be looking so much at the product once it's licensed, there are so many people that are interested in looking at different ways to use these products. We're going to see a lot more, definitely.
We're going to see a load more data.
That's true for any new product.
Yeah, and any new therapy. I've got a question, actually. This is going to be really controversial because I've got 10 minutes and no one's asking questions. So, do you feel that all modalities and interventions, be it pharmaceutical, non-pharmaceutical, or nutraceutical, are judged on the same merits with regards to clinical evidence? in that the quality of trials that come out for the different areas could be argued to be of different merit. How do you feel about that?
That's a tough. That's a really tough one. I guess probably the first thing just to mention here, going back to us talking about evidence-based, evidence-informed, is you're absolutely right, because there's very few of those meta-analyses at that kind of that quality of evidence, purely because there's not the trials to feed into those. Whereas if you look at human medicine and we look at the numbers enrolled in a clinical trial, they're enormous, and we don't have that. So, and I suppose the other thing, maybe also controversial here, is that people tend to look at things that either they find interesting or where they feel is going to be a benefit as well. So, do we not investigate, for example, the nutraceuticals, because we are always thinking about the pharmaceutical agents, and we tend to pick those as our clinical work.
And I'm going to say fat. Let's chuck it out there. We did one of our reflect after the Zero Pain Reflect, which is a subscriber benefit. I dug into the link between obesity and arthritis, which I know you have done. We featured, we put your link to your discussion with Alex German in there. Fat needs to be sexier. We need to pay more attention to the fat. If we get really excited about drugs, but actually let's just get some weight off that dog, because that fat is having a hugely detrimental effect. If you looked at, I guess if you scored cane and brief pain inventory quality of life across a period of weight loss, we would see those scores improve over time, just as we would see those scores improve if we use drugs in those patients. So actually those owners that are really drug averse, if we can, and thinking about this in a contextualized setting, what's the best thing for that patient? Let's get some weight off it. If that owner really doesn't want you to touch their dog with drugs, then we need to focus them on getting the weight off the dog.
Okay, so that's our project for 2024 fourth quarter. We're going to make obesity trendy. And actually, we're pigging back off the dental sector. They've been saying for years, how can we make dentistry sexy? Because it is such a cause of chronic pain. Yeah. And I think for me, I would like everybody that listens this weekend to go away and reflect on how many areas of chronic pain isn't being managed, not just musculoskeletal that gets the limelight. We've got visceral, we've got, skin, dermatological pain. I think about living with ear disease. That breaks my heart when people just go, oh yeah, let's give him some ear drops. He has it every month. So let's expand our field of view. Okay, we've got a great one from Jamie Foster. This is great. Rebecca, I'm not ignoring you. Does Zero Pain Philosophy offer memberships to rehab professionals and hydrotherapists?
Yeah.
There you go, answered. Jamie Foster, I am in Texas and I struggle with how to discuss some of the differences between guidelines here and versus there. For example, Grapiprant is recommended on an empty stomach on labels there, but is, to my most recent knowledge, not labeled in this way in the US. And studies show a significant difference in absorption on an empty stomach. Do you have recommendations for managing and identifying these differences, which is very applicable with our online access to information now?
Yeah, I guess first and foremost, it's important to recognise that your advice has to be tailored to the where you are located from a regulatory point of view. So I think I would take that approach to start with. Okay, we know that there are differences in absorption. It'd be interesting to know how significant those differences actually are. But you're then either in a situation where you're saying to the client, right, let's use this product off label. So that's one situation. Or you're in a situation saying, well, actually, we are abiding by the local licensing regulations, and this product is not achieving optimal pain control in your pet, your dog. So what else are we going to do? It probably drives you closer to the right, let's think about all of the other things question. I think that's the kind of fork in the road for me. Either you're going to go off label with your client and your client understands that, or they're the type of client that says, no, absolutely, we can't go off label. okay, right, let's drive the conversation towards making sure we do everything else for that pet, the weight loss, the diet, the exercise, all of those physio, hygiene.
Yeah, I love it. Now, this is close to my heart because I love new grads, young vets. I think that we need to look after them. There's a very high attrition rate in our industry. I think a lot of people come in and rapidly realise it's pretty tough monkey, not just the science and the workload, but also the changing public perceptions of the vet industry. So, Katie Miller, bloody good question. How would you best encourage new vets or vets who feel less confident in communicating this whole new world of contextualised care? How can we learn a set of skills required to provide this co-produced care? Wonderful question.
That's a tough one, isn't it? And I think I guess that this has to start in the vet schools at some point. We've got to embrace that. We talk about communication skills. I'm a bit too old school now to know where that's gone to from the days of the VDS coming in perhaps once when I was at Liverpool. But this starts with, this is just normal. It's such an important part of the practice of veterinary medicine to be able to communicate both with our colleagues, but with those pet owners. And I suppose if you are in practice and this is something that you feel like you want to observe in different ways, then getting out there and seeing practice, observing those people. We know that there's an art to vet medicine, and that there are people out there that have got great skills there. And certainly we really encourage and embrace people to come and visit at the hospital, join the specialists in seeing how they interact with clients, how do they go about having those difficult conversations, getting out there, observing, and finding somebody perhaps that you feel like you can, you've got an engagement with, and you can join them in that. Not saying this is easy.
It's not easy.
There are those clients, aren't there? We all have them probably every day. There's challenging clients that you try your absolute best and they throw a spanner in the works.
Yeah.
I'm gonna shout out to a fellow podcaster, the Vet Vault. They've just done a really good podcast with a guy called I can't remember his surname. He owns practices in Australia. Hugh and Gerardo, that founded the Vet Vault, based in Australia. Really interesting. Listen to it. I think the title's quite controversial. It's like, the vet profession is not here to make you happy. It is a really good podcast. I've done some stuff with them. They're a great pair of guys. I would say, okay, this is about local support, and it's about that team approach. So if you're thinking, well, contextualized care, as a practice, this isn't just relevant to pain, it's dermatology, it's every single consultation we do. Let's have the discussion, let's get on the same page in our practice. As a new grad, you absolutely need support of the people around you in the practice, because that is what's going to carry you through. And it's not just those experienced vets, it's those experienced nurses that will be there. They will literally carry you through your career. So
yeah, definitely. I'm just gonna butt in, because I just want to give a really practical tip to new grads and young vets. Is find an area that you're starting to feel confident in, that you're the science and you've got it down pat, you think you're good. Then play with your approach. So then play with your communication, have that sentence, have that greeting, have that mannerism, have that body approach, and just start seeing what ones are working for you. So I don't know if anybody's old enough for Mr. Ben, who goes into the fancy dress shop and he just keeps changing who he is. There is a little element that you have to grow yourself and grow into a practitioner that's a bit of a social chameleon, but you will get there. Matt, Carl, what an epic start to the next 2 days. I love you both so much for doing this. We're going to have to jump out now. So thank you, guys. Please leave this session, go back to the lobby and join your next session. Dear friend of mine, Katie Smithers, is introducing us to how to set up and the benefits of running a mobile pain service. So head there now. Thank you, guys. See you later for the day.
Thank you, everyone.
good luck, Katie.
Thanks. Thank you.